Thank you very much.
Thank you, Professor Nasser. We have two online presentations ready. Okay. The next presentation by Professor Mahmoud Salah from the Holy Places from Saudi Arabia. His talk is about endovascular versus open surgical treatment for renal and visceral aneurysms. Discussion will be at the end of the session. Sure. Good morning, Dr. Mahmoud. We cannot hear you, Professor Mahmoud.
The problem.
Okay, we are hearing now.
You can hear me now?
Yeah.
Okay, thank you very much.
Thank you.
I wish, Taban, I'll be with you physically because I didn't miss this meeting for years, yeah. But unfortunately, I had to do it by Zoom this year. I need to thank Dr. Mustafa Suleiman and all the organizing committee and the chairpersons for their great efforts to do this meeting. I'm going to talk about visceral aneurysms, endovascular versus open surgical management. Concerning the prevalence, they account only for 5% of all intra-abdominal aneurysms and occur in about up to 2% of the general population. 1/3 of them associated with non-splanchnic aneurysm, iliac, AAA, femoral, whatever. 1/4 of them presented ruptured with the high mortality reaching about 100% in pregnant ladies. In order of frequency, the aneurysms are 60% of them occur in the splenic artery, 20% in the hepatic artery, 6% SMA, 4% in the celiac, and the other 10% in the renal and other branches. The traditional indications for therapy, any symptomatic patient, any patient having real symptoms, any pregnant ladies, this should be treated aggressively. Renal artery aneurysm when reaches 3 centimeters or more. Any visceral aneurysm, celiac, SMA, splenic, hepatic, diagnosed should be treated actually because they have high mortality rate with rupture. With the advancement of the radiology, we started to diagnose more cases of aneurysm. This is supermesenteric, and this is splenic aneurysm, huge splenic artery aneurysm. And you can see this is also one of the hepatic artery branch from the celiac. The outcome of the endovascular therapy, this actually is a little bit old study, but it's having a very good number of patients. They, as you see, they managed to treat splenic and celiac, SMA and hepatic, and they had good number of cases. The technical success rate was nearly 100% of nearly all types except some of the hepatic. The mortality and the complications were in the acceptable range, except this 50%. Of course, this is 50% of the celiac branches were dead, but actually don't be deceived by this, because if we return back here, they did only 2 cases of celiac. So one of them was complicated and the patient died. So they that's why the 50%, but actually it's a very deceiving number. We should not look at it like that. Concerning the renal artery aneurysm, this is again a more recent study, evaluated more than 800 renal artery aneurysm in 760 patients in 16 institutions. 75% of them were asymptomatic, ruptured were rare, and there was no mortality even with the rupture. Renal artery aneurysm repair was done for severe hypertension, cured about 30% of patients and improved about 26% of patients. 3 patients had ruptured, no death, as I just mentioned. Aneurysm growth rate was very low per year. No difference between the calcified and the non-calcified aneurysm. So the fate of the renal artery aneurysm is much better than the visceral aneurysm. Some technical tips, whether for the endovascular or the open. Of course, if we are going to do endovascular, antegrade access from the arm, especially left arm, is much better. It gives you good accessibility for all the visceral aneurysms. Use stent graft and coils as the first line of therapy. In case of infection, of course, we need to do open, and we use vein graft. Possible ligation, not necessarily I have to bypass this, I have to excise the aneurysm and make a bypass. Ligation is still an option. Auto-transplant kidney is also can be considered for renal artery hilar aneurysms. Some of our cases, this is the superior mesenteric artery aneurysm, and this is the construction. This is during intervention. As you see, there is a branch immediately after the aneurysm, and there are many branches coming out of this aneurysm. So we were a little bit concerned whether to cover with a stent graft, we will lose all these branches. But actually we did this, and this is the stent, the aneurysm disappeared, but also the branches disappeared. But just the picture will not give the real situation. This video can give us the real situation. You can see that all the branches are filling again from the other branches. So the patient did not lose any of the branches. These are branches for the left colon, and it was saved, alhamdulillah. This is another case, superior mesenteric, very near to the ostium. And this is after the stent graft. This is a splenic artery aneurysm, very tortuous splenic artery. This is after we put stent graft. As you see, stent graft was put, but yet the aneurysm is still filling because it was not covering the whole mouth. So we have to put another stent graft in the as an extension to the first one. And as you see, in spite of the tortuosity, the aneurysm disappeared, alhamdulillah. This is a algorithm to know whether to do endovascular or open. It's looks like a little bit complicated, but it is not actually. So I tried to simplify this in this. When to use which? When I use endovascular and when to use open. Or if you have elective aneurysm, you are free to do both. Open is correct and endovascular is correct. For the distal branch point, like the one we saw, again, you can do it open, you can do it endovascular. For the hilar aneurysms, open is the best option for this. For the mycotic aneurysms, where there is infection, again, open is the best option. For the ruptured aneurysm, you are free to do or even open or endovascular. If you can see that you can do it endovascular and you have the tools, go for it. If not, open is still a very good option. For the end organ ischemia, open is number one. For the saccular aneurysm, the endovascular is the best option. In conclusion, we should treat all symptomatic and pregnant patients. We, once diagnosed, you should be treated. Treat all visceral aneurysms identified. Rupture is catastrophic, especially in the visceral where there is the peritoneum can accommodate a lot of blood. It's not like the renal. The renal, we can treat it even when it reaches 3 centimeters. The endovascular treatment includes stent graft and coil embolization. This is the first line of treatment. Open surgery includes bypass surgery and ligation. Again, ligation is still an option. You can see many patients with occluded celiac, but the SMA and IMA are patent and there is no problem. You can see the reverse, SMA blocked, but still the patient has no problem. So ligation should be considered. Preservation of the antegrade flow is preferred, but not necessary. This is what we mentioned by ligation. If I can preserve the antegrade flow, it will be much better. If not, still ligation is an option. Mycotic aneurysm should be treated by open surgery, except in very few situations, if in an emergent situation or as a temporary treatment that the situation now cannot allow for open surgery, so I can put endovascular stent graft and to be treated later by open surgery. Thank you very much.